There we go. I think we got it. A little technical locking in here. One of these days I'll figure out how to do a screen share so we can get nice high quality video. I am a doctor. I used to be an engineer. Graduated EE and it's like that's long gone. Left me. Stuck with a doctor's ability to figure this stuff out. We do have intelligence. We get to wave to people. We're getting a big okay. We're not crooked. We did have some questions. We'll be on in about 10, how many minutes now? I don't have the time. 7 minutes. T-minus 7 minutes, says my Navy man here. I'm sorry, my Army man here. My bad. Had some controversy. We had some questions that people wanted answered. This Captain Crozier thing from last week came up a few times. We had some questions about testing. We're going to get to some testing at the end of this. What else do we have questions about?
You know, that was kind of my question is what's changed since we were here a week ago?
That's actually interesting. Yeah, it's a good question. There's a lot of stuff kind of popping up that has Lippy here has a nickname from a while ago, a little fired up that we're going to talk about today. Stuff you guys need to be, let's turn this around. Things that you guys need to be looking for when you read all this stuff. All these headlines come out. And there's a couple headlines here that, not these headlines that we're just looking at, but you just gotta read behind the headline to figure out what's really going on. Happy to answer on Facebook. I'm sorry I've been a little negligent. I've had so many messages come in my way that I've been a little slow in getting back to everybody, but I've been trying. Great, some really good ones. People asking questions about getting ER visits covered, which if you have insurance, that should be covered through your insurance plan. That's a requirement. That insurance plans cover co-pays, deductibles, everything. Basically, if you're being seen for a COVID evaluation, that's covered by insurance. And then the government, CMS, has agreed to cover uninsured patients as well. There was a great, someone sent me this great, for all you bikers, sent me this great article about how the spread of droplets happens behind bikers. It's just basically the slipstream, right? It's the whole idea you ride in a pace line is stuff goes right behind you. Now, how infectious are these droplets? Kind of a little bit different issue. Now, there's actually some slides that kind of talk about that later. Kind of have some interesting stuff to show about aerosolization, micro droplets versus droplet spread. Let's see, what time is it? I got a few minutes.
Somebody asked about the pulse ox. The pulse ox.
I'm waving to the hand surgeon. I've got a hand surgeon watching this. Got to be careful.
His son made something interesting, and I can't remember. I think he did 3D printing or something.
3D printing, nice.
Yeah, Luke did something. I don't know exactly.
Yeah, we got some nice face shields from a 3D printer this week. That was real nice of the folks to do that. That was nice.
But somebody asked about pulse ox. Pulse ox measures your blood oxygenation level, and we use that to determine how sick somebody is, especially if it's respiratory related. And somebody asked if it'd be worth getting one. I wouldn't get one for this. I wouldn't think it would be that helpful. I think you're going to know you're sick in other ways. You're going to just feel short of breath, and your heart rate's going to be up. And they'll measure your pulse ox if you go into the hospital. It would be one of the last things to go, but a good tool.
Okay, so we've got a question here. It was about, they wanted to hear about Captain Crozier here, who's on the left, this left article. Navy relieves captain who raised alarm about coronavirus on the aircraft carrier. So we're a little bit of a week late with this one. I just had a slide that was kind of stuck in the middle of the last week's presentation about this. And Captain Crozier was actually Navy class of 92, and for those of y'all that don't know, Ed is an Army Ranger class, Army class of it's the same year,
West Point class of 92.
West Point class of 92. So he was in Dr. Crozier's class, and I wanted to ask him what he thought about the Navy relieving this captain who was basically trying to feel like he was doing the right thing for his 5,000 folks on Navy men on this aircraft carrier.
I think he's a hero. And he might not have gone about doing it the politically correct way, which might have cost him his career. But I think he's a hero. I think he wasn't getting the help he needed, and so he tried to take care of it the best way he knew how. That without knowing any of the details, that's just a guess. Wanting to think the best of Captain Crozier.
Yeah, and very similar. There was a physician who was fired in Seattle. This is about a week or two. I think it's more like 2 weeks ago now. And he wasn't actually fired. He was actually removed from that particular hospital, reassigned elsewhere for speaking up against protective equipment at the hospital he was working at. And really, there's two sides of this story. I kind of know a little bit from the other side, where he definitely probably did not go around about this the right way, kind of going through the correct channels to have that done. And a lot of times when people are making a lot of noise, when there's a lot of confusion with coronavirus going around, there's kind of a right way to do it and a wrong way to do it. And if you do it in the wrong way, some people would argue that you're actually doing more harm than good, just by bringing too much attention to that situation. So, the truth, it's always somewhere in between, usually at any rate. And that's probably what happened here with Dr. Lim. This is something about titles you just got to be careful for. This is a physician in New York City. And if you read down here at the very bottom, I don't know if you can see it, but New York City doctor claims COVID-19 is not really what they say it is. We are treating the wrong disease. And so this is a YouTube video that was passed around quite a bit with just people reading that tagline like, oh, hey, COVID is a hoax and so on. If you listen to his video, what he's talking about is COVID is not quite like flu and these other respiratory viruses, that it's treated in a different manner. It looks like high altitude sickness is kind of the way it acts, but it has to do specifically more with the way we treat it rather than, coronavirus or COVID-19 is the causative factor. So again, don't just read the tagline. You have to understand what's going on behind it. He actually has a very intelligent video where he speaks very specifically about how we should be ventilating these patients and how we should be taking care of them. So it's an excellent video, but just the wrong tagline here and kind of led to the wrong message in a lot of people. So it's 8:30. I'm going to go ahead and get started. Thanks everyone for joining us. I will apologize a little. There's a lot of new stuff here that I want to bring up, but I also there's a lot of new viewers here, and I just want to go through some of the older kind of very salient points that I want everyone to remember about this particular illness. So I'll try and shoot through those as fast as possible in the interest of not kind of boring the people that have been through it before, okay? Yeah, I don't want to do that. So all right, so COVID-19, let's work together and stay apart. I think that's kind of our message. We need to all remain physically distanced from each other. Remember, COVID-19 is coronavirus disease 2019. It's also known as the SARS coronavirus 2. It is a very simple particle. A virus is very simple. It is not able to live on its own. It's got these spike proteins. It's got the membrane that has a few proteins on it, and then it's got a single strand of RNA. There is no machinery here for it to live on its own. If viruses were just left out in the desert with no organism to support them, all viruses would die if that was the paradigm that they lived in. However, we will always have bats, we will have mammals, and we will have people where these viruses will get spread around. This is the Wuhan market where this virus was first detected. Remember, it is a respiratory virus. It causes the lungs to look like this. Normally, this should be black out here. It should be black out here. But all this fluffiness is fluid that is being retained in the lungs as a result of irritation from the COVID virus. This is a more severe picture over here, and this person actually is on a ventilator, a breathing tube, which people have seen lots of x-rays. Notice this little stripe that's a breathing tube. We do know that it affects older people. This is ages 0 to 9 and so on up to older people. The older you are, these are death rates. Once you contract this virus, becomes very high when you're older. These are South Korea, China, Italy. These are 3 different countries, just data from 3 different countries. However, we do know that it affects younger people as well. These death rates in 30 and 40-year-olds is higher than death rates from flu, from influenza. This is from Washington Post that came out this week, actually April 11th. Medical databases show that 1 in 10 people who are hospitalized, who are middle-aged, will not survive if they're admitted to the hospital. Now, don't take that to mean that going into the hospital is the end. I mean, if you need to be in the hospital because you're having trouble breathing, you need to be in the hospital. It is not that, but it is the people who have the illness to the point that they need to seek medical care. This is what's going on. This is not a benign disease in middle-aged people. And who are middle-aged people? It is people 45 to 54. That kind of hits home with me. And I think it hits home with Ed too. And you're a little bit older than that, 13%. But even those 20 to 44, we've had deaths in this age group right here from people that have coronavirus. We've learned some early lessons from the Diamond Princess. We know that isolating people makes a difference. We also know that there's a high occurrence of carriers who are asymptomatic. And this was shown in a study in Nature magazine where virus is readily shed early in the infection, well before symptoms emerge. And the bullet point, or the important point here, is viruses that express themselves very early. When people get sick very early, it is almost better than late, because there's no chance for asymptomatic people to go out and spread this disease. So we know that asymptomatic people can spread this disease, which is one of the more dangerous things about this virus. Worldwide, last week we were kind of up to 1.2 million cases. This week we're at 1.8 million cases. Deaths started at 4,000 back March 10th. We're just over a month later, and we're now up to 110. We've passed the 100,000 mark this last week in number of worldwide deaths. Now, one good thing to note here is see, there was it went up by about 5 times here, went up by 2 times here, and then this last week here, it's only gone up by about 1.5 times. So the rate of increase seems to be slowing down. Now, this is all determined too by testing. There's a lot of people that are not tested. Some countries are not testing. There's a suspicion that China is no longer reporting their numbers. China, if you look up here, was at 80,000 back on the 10th of March. You look here on April 12th, and China's at 83,000 cases right here. So we think there may be some underreporting going on in China. This is the United States, 143,000 cases. This is on March 30th. About a week later, we were up about 2.5 times. And then in the last week, we have gone up under half. So the new cases seem to maybe be slowing down in the United States. Number of deaths has gone from 2,000 up to over 20,000. And this was yesterday, April 12th. Now, this is kind of an interesting graph. You say, well, it's going up and up and up and up and up. And so this graph here is the same as this graph up here. But if you turn it into a logarithm, which kind of shows kind of the rate of acceleration rather than just kind of the absolute number, whenever you see this kind of pattern on a logarithm scale, that's usually a good sign that things may be slowing down a little bit. So all this physical distancing that we're doing is probably making a difference. Now, this is the IHME data, and this data has been questioned by a number of people. This is kind of that predictive model for where we're going with number of deaths. Remember, today we're at 20,000. Back on March 28th, it was predicted that we'd be about 81,000 deaths ultimately down the road from coronavirus. That jumped to 90,000 cases. Then last week it went down to 81, and now this week we are down to 61,000 cases. Remember, these are only guesses, and there's a big window. I mean, even these windows up here said the cases would be between about 40 and 150,000 or 160,000, I think, deaths. So this is still within the window of what those mathematical models predicted. But right now they're predicting, what is this? Maybe 30,000 on the low side, but they still could go as high as 160,000. These are the cases by city. This over here is the cases. This is the deaths, and this is Atlanta over here to the right. So the cases. Why is it so dark down here? Can you turn those lights off, Ed? Just right there on the switches over there. Let's see if we can help you out on the bottom. No, just turn them all down. Does that help? I'm going to try something here to see if we can. I don't know why the bottom of that screen is. I'm going to try and help you out with the bottom of the screen a little bit, but sorry about it looks a little dark on the bottom of the screen. Anyway, yeah, why don't we just leave it like that, Ed? At any rate, you see this is, again, is a kind of a logarithm scale here, and New York, which is obviously kind of the worst city that's been hit by this, is really starting to kind of tail off. And so the number of cases, instead of doubling every 2 days, which is what this line represents, is now doubling every 3 days over here. So the cases are still going up, but the rate of increase is decreasing. And you kind of see a similar pattern in several other cities. Washington, D.C., still kind of going up at the same rate. Same thing with the deaths. The deaths are still climbing in New York, but they seem to be tailing off a little bit in all these places. So we do know, or we do believe, that physical distancing is helping. Look at Atlanta, we're doing really well here. We're really tailing off in number of cases and deaths. So Atlanta is see how it's here, up here, it's kind of more on maybe the Seattle trajectory, one of these lower trajectories down here. State of Georgia, estimated deaths, hasn't really changed much. It was about 3,200 back on April 2nd, and then April 9th, which was the last time I saw that this website was updated. It's still about 3,500 deaths. Right as of today, we have 13,000 cases reported and about 500 deaths in Georgia. Remember, this is just a real important point. This is not, I hate the word social distancing. This is not social distancing. We need to be physically distant, but just not socially distant. This, again, is my niece Ruby, and this is my dad and Denise. All three of them have airway issues of one point or another. They live together, so they're not physically distancing here, but they are not going near anybody right now. I'm sorry, my dad doesn't have an airway issue. He has a cardiac issue, but Denise and Ruby both have airway issues. Very bad if they caught COVID, and they're being very careful and by the book about staying distant from folks. Remember Philadelphia and St. Louis. Philadelphia, huge parade. St. Louis canceled the parade. This is the flu epidemic of 1918. This is what happened in Philadelphia with the death rate per 100,000 population. St. Louis had the flattening of the curve and did much better with half the number of deaths for the same number of people infected. Of course, New Orleans and New York. This is what was going on in February in New Orleans. This is February in New York, two of the worst hit places in the country. Just a comment. I mean, this almost looks like an NBA basketball game, down here. This is actually a play, but, just hats off to all of our, NBA and all these high dollar, all of our professional leagues that saw this, and they called things off in early February. I mean, just kudos to just being able to kind of turn the other way when they could have been making a lot of money, and understanding that this getting people this close to each other was a problem. So we just talked about New York and New Orleans. And two other hotspots we're seeing now is Chicago right here and Detroit, Michigan. There's kind of a lot written now about kind of inner city and poverty and people not really understanding COVID as well as other places. Maybe some social disparity, a lot of written in the literature about that right now. Other places, we got Miami, of course, LA, and Washington, and then San Francisco Bay Area. One interesting thing, though, that we're seeing across the country is that hospitals are really kind of being overrun here in New York, some in New Orleans. Starting to see that a little bit maybe in Michigan and some in Chicago, but they're not really seeing that in the other places. All of the other places, the hospitals are maybe nearing the tipping point at some places, but really not seeing kind of the, just the overrun catastrophes that they're seeing in New York and New Orleans. Okay, so avoid coughing and sneezing, stay 6 feet away. And, why is this? Is because transmission is believed to be from direct contact. But, and remember, when you go to the grocery store, I just see this every day. Be careful, wipe these things down before you touch them. Door handles, people wearing their mask, but just freely touching door handles. And then any kind of, handle, we're not going to the airport anymore. And then, of course, touching things of your neighbor, stay away from that as well. Okay, so direct contact, definitely, we feel like that is a definite cause or transmission of COVID. And, of course, the coughing and sneezing, kind of inhaling droplets that somebody coughs or sneezes. And coughing and sneezing can go, 6 to 7 feet away. So remember what I showed you last week? These are droplets. When someone coughs, kind of all these droplets, this is about 2 feet right here. These droplets come out of the mouth and they just kind of go and they just land on stuff. So that's the desk. That's a doorknob. That's, whatever may be in the market that you're picking up to, carry to the cash register. These are the droplets, kind of the goop that you can't see that's sitting on stuff. That's what we have. We have to be careful of that. That's what droplets are. We also talked about sneezing. This is kind of this gaseous cloud that when people sneeze or cough, gets shot 6 to 7 feet away. And you got to be careful for walking through this right after somebody coughs. Now, one thing that actually has been in the news here the last week, that's another very interesting concept that we don't really understand, is this idea of microdroplets. It's similar to a cough and a sneeze, but these particles may stay suspended in the air. And I've got some video and some things to kind of show you what this means. Now, I want to preface this that we don't really know what the meaning of this is for COVID. We do know that microdroplets are probably very important for things like measles, things like chicken pox. These things stay suspended in the air for a while. TB would be another example. But we also know that while microdroplets like flu, RSV, adenovirus, a lot of these things we see in the wintertime, a lot of these upper respiratory infections are carried in microdroplets. The microdroplets are not enough of an exposure to hit other people and cause disease. So while you're walking through flu microdroplets, you're not going to get flu that way most of the time. It's going to come from direct contact or sneeze. So where did this come from? A lot of this research come from? It came because there was this article that came out, and this is in New England Journal Watch, that maybe just normal breathing or being around people can cause RNA to be detected within several feet of individuals. So I'm sitting here talking, I have a mask on right now, but if I didn't have a mask on and you took a swab several feet in front of me, 40% of the time you might be able to pick up RNA if I wasn't wearing a mask. But if I'm wearing a mask, it would stop that. So this is an interesting video. So this guy here is talking to this guy over here. And what's going to happen when I start this video is it's all going to go dark, and there's going to be some lasers that are coming across the screen, and you'll be able to see what these micro droplets are. So you can't see his face very well, but he's talking over here. There's another guy talking over here, and these are all these little micro droplets that contain virus particles if he had a virus in the air. And this is kind of looked at a little bit different way. All these little things that look like little flies or something, those are micro droplets that this person is being exposed to. So this is a video simulation of what it might look like. This person over here, if this person was infected, this is what microdroplets would look like in this room of people. So this person coughs. All this red stuff is microdroplets. All the other droplets that fell to the ground are not included. And this is a kind of a time-lapse video. This is 5 minutes, 6 minutes, 7 minutes, 8 minutes, 9, 10 minutes later, these microdroplets are all still sitting out there in the air. And this is one reason why measles or chicken pox is very highly infectious, is because those particles mean something and can actually infect all of these people within a room. We know, though, that with flu and other viruses, that's not the case. So at any rate, the point is that there are microdroplets, and we're not sure the degree of transmissibility of coronavirus. Now, there is some literature out, that a very good point that I was reading today from a researcher, I believe is in Chicago, that actually talks specifically to this point. And what he says is, well, coronavirus seems to be transmitted at a rate more similar to flu and other types of coronaviruses and adenoviruses rather than mumps. I'm sorry, I said mumps, but I meant to say measles and chickenpox and TB. If you are in a household with somebody that has measles and you're not immunized against measles, your chance of getting measles is extremely high, 85-90%. And that's true of both chickenpox as well as TB as well. But this is not true of flu and other type viruses. And so what we are seeing is transmissibility amongst family members more in line with flu and coronavirus. So the kind of the thinking is very questionable as to whether this is a route of transmission or not. Good news is these droplets, if you're inside, don't really go anywhere. This is inside. Now, look what happens when they open a window or there's any venting to this room. You'll see very quickly all these droplets scatter. These micro droplets just go away very quickly. So this is like when you're outside, micro droplets don't really exist. They kind of may go from, one bike rider in front right past the guy behind, but they're gone very quickly, and you'll kind of see them just kind of disperse right here on this video as well. Okay, so we talked about vaccines last time. They're really going to be the ultimate cure. They're going to take more than a year. If they're successful, they will be the ultimate cure. They're going to take years to develop, and earliest is at least 1 year. And we talked about why. There's multiple phases of studies. You can have a successful vaccine, but that successful vaccine that you create could wind up having more downside than upside. So there's a lot of steps involved in making a safe vaccine. What speaks to the benefit of vaccine? I can give you the example of measles. Measles worldwide kills 100,000 people, 100,000 children every year die of measles. And it's mainly due to lack of vaccination. Well, how does measles kill children? It's generally children, but older people as well. It's a respiratory virus, and it kills basically from pneumonia and dehydration. Some communities that have very poor medical care, the death rate can be as high as 30%. Vaccination efforts have saved an estimated 21 million people in the last 20 years. So vaccines, not prevalent everywhere worldwide, kill lots of people. However, it's been largely eradicated in the United States. Why? Because we have vaccine. Now, what happened in 2019? I think a lot of us remember last year there were 1,200 cases in the United States. Who was infected? 89% of these people were unvaccinated. And it was in areas where they said, oh, we don't need vaccines. We don't believe in vaccines. And sure enough, these are the populations that got hit with measles. So the point is when we are vaccinated, travel very well. Now, we all know that the influenza virus vaccine is not perfect. It's about 50, 60% in any 1 year. But even that 50 to 60% gives us enough herd immunity such that flu doesn't overrun our communities, every year. But still, we get between 5, 10, sometimes more thousand deaths in any given year from flu. Avoid the hype. This was a slide I showed last time. These were all related to the Spanish influenza, Boyer's massage parlor, Horlick's malted milk. Just the point with this slide is just be careful of what you hear. Today's kind of rendition of Horlick's malted milk is Tamiflu, and we talked about kind of all the hype and everything involved with Tamiflu 10 years ago, and how it kind of was a big moneymaker for its drug manufacturer, but didn't really work very well at all and caused lots and lots of side effects. Okay, so how does that apply today? Well, we have hydroxychloroquine, which some studies are positive, some show no difference. And remember, there's always the side effects of these medications. We do have trials underway, but again, always read the fine print. Read read behind the title. Remdesivir is an antiviral, and there was a report that came out. 2/3 of severe COVID cases improved on Gilead drug, and what they're talking about is remdesivir. Now, what it doesn't tell you And this is great. Wow, let's give remdesivir to everybody. Sounds great. 2/3 of people, we're going to heal them. Well, what it doesn't tell you is what the article is the kind of the fine print of the article. Interpretation of the results of the study is limited, small size, short duration of follow-up. There's a lot of missing data and lack of randomized control group. So I'm not saying this study is not important. What they did suggest that maybe it is helpful, but maybe just under 2/3 of the people would have done well anyway. Without a randomized control group, this study is questioned. They actually kind of talk a little bit more in this study that it was safe and it might seem to help people, and they actually advocate for a larger study of remdesivir to see if it actually works. There are trials underway. Hydroxychloroquine is one. Remdesivir is what I just mentioned, and there's a couple HIV medicines that are being studied on large trials now. So hopefully we'll have some answers for this in the next few weeks as to which of these medicines may or may not be helpful. I'm going to talk a little bit about the Chinese experience with these medications, and unfortunately, they didn't find any of them to be very helpful in their patients. Remember, there's convalescent plasma. We talked about it last time. Basically, you take antibodies from someone who is healed or from COVID, and then you give some of those antibodies back to people who are ill. We know this is effective in small studies, and it's also been very effective with Spanish flu, with Korean hemorrhagic fever. We also use a form of this with Crofab for people that have been bit by a snake, as well as people that have been bit by bats who were prophylaxing against rabies. So there's very much reason to believe that that convalescent sera will help. Okay, so this last week, I was on a very interesting conference call with a bunch of Chinese physicians from the Central Hospital of Wuhan. It was fascinating. There were probably about 8 or 10 physicians giving their experience for COVID. And remember, Wuhan is where the first cases were reported. And it was very interesting. A lot of the stuff that they talked about was stuff that we do here, and they have a lot of the same results. The initial measures that they put in place, lockdown of Wuhan. As soon as they started seeing that there was something bad going on, and they saw this SARS virus 2 coming out, they immediately locked down Wuhan. They had stay-at-home orders. They had Fengkang shelters. And what happened, what these are, is makeshift hospitals. So what happened when their hospitals started getting overrun with this somewhat mysterious disease, they started cohorting patients with this disease into these outlying hospitals rather than bring them into their main hospitals. They also had quarantine points where they wouldn't let people out to infect other parts of China as well. Their protective gear, because they were scared of what was going on and they didn't know quite as much as we did, they were definitely gowned up beyond the way we were gowned. But look at these guys. They look like you and me. They're giving us peace signs or peace. This guy's giving us peace sign. They had a much more involved respirators than what we use now. But again, they were very early in the course of this disease and didn't know quite what they were dealing with. The medical presentation, very similar. Fever, dry cough, progressive dyspnea, ARDS, that's kind of the advanced form of the disease, diarrhea, fatigue, chest tightness. They did note that there are a lot of asymptomatic virus carriers. They also knew that people above 60, the old age, obese, and presence of comorbidity led to worse outcome as well. Lab studies they went over with us, and there's a number of lab studies here that we use a lot of these in the United States, CRP, D-dimer, LDH. And they knew that parameters or a warning is when any of these parameters went way off, went either way high or way low. They did say that rapid progression on chest CT seemed to be worse, and when respiratory rate was high, people tended to do worse. Here was a patient that they took care of, and again, remember the x-rays. This is actually a CAT scan of a bunch of fluid that's developing in this person's lung. And they shared with us a bronchoscopy that they did on one of their patients. And the interesting thing about this disease versus other disease is that the airways, kind of the big airways, don't seem to be affected at all. Remember the slide I showed last week of just fluid filling up in the air-filled sacs of the lungs. So when people are frequently not doing well in the ICU and you're having trouble ventilating them, they're not getting good oxygen, you'll put a tube down into the airways of their lungs to try to suck out all the goop so that you can get the oxygen to their distal airway. But what you're seeing in this picture over here is these are completely normal airways here. There's no goop, if you will. There's nothing to suck out. The problem is all distal, and doing bronchoscopy is not very helpful. The medical treatments, and I won't shoot through all these slides, but they did talk about test. This is probably one thing we're kind of failing with in this country is we're just not testing. They tested very early, and if somebody tests positive, they just isolated them. They got them into a quarantined area. They took them away from their family. In fact, a lot of these doctors who were treating these patients, just because they were high risk, they took them away from their families. So these doctors we were talking to said, I haven't seen my family in 3 and 4 weeks. After you test them, isolate, and cut off the passive infection. Basically, don't let these people out to infect other people. They found that isolation at home was not reliable, so they would isolate these people into remote areas away from their family as well. My personal opinion is I think we're doing a pretty good job. I do see kids out playing basketball. I see kids out there skateboarding. But I think most of us adults, are doing a better job, and I think we could maybe do a little bit better job of keeping, our groups in 5 and 6, friends from kind of cohorting together. Antiviral treatments, these are a bunch of treatments that they tried, and what they found is no one was the winner. And all of these treatments are treatments we're trying over here, and we're actually trying some trials, some case controlled trials. We're going to give one person this, we're going to not give the other people, anything, just a placebo, if you will, to see if anything's help. But again, they didn't find any of these things to be terribly helpful and stand out. This was their center here in Wuhan, and they had death rates of 4% across China, and in Wuhan, the death rate they had was 5.1%. This is a patient here that they took care of. This is one of the doctors that lectured to us. And this guy here had been through ECMO. People who know ECMO, it's actually a bypass machine where your whole body system is failing, and you go on to what people would go on to for like if you're having heart surgery done, where you go on to complete bypass. And he was on ECMO twice, had been intubated several times, and now he's out of the woods. And this guy actually made it. And just like we do in the United States, thumbs up. What did I learn? I learned that a lot of the treatments we're doing here, they were doing in China. And maybe even the bigger thing I learned is these people in China, we're kind of told they're bad people. They're hiding information from us. They're people just like us. They want to take care of their patients. Very, very proud people. They all spoke English. I can't speak a lick of Chinese. And at times when they were trying to explain difficult concepts to us, they stumbled, and you could tell that they were frustrated with some of their English. But you could tell that they were very, very proud of the work they did over there. And we talked to them for like 2 hours on the phone. It was just a real rewarding experience. It shows that the whole world, we're just one people, and we all are just trying hard to lick this COVID thing together. And they were very proud of telling us their experience about this is the pattern of disease you do, and this is when you might ventilate someone, and this is when you want to do this. And they took our questions, and they actually sent us a whole little PowerPoint, and then they took down all of our questions and wrote answers and emailed those back to us. It was really a special experience. Okay, so this is what kind of has me mad. Be careful who you listen to. And I chose Dr. Ayadura, who is an MIT PhD. And the title here is Dr. Ayadura, MIT PhD, crushes Dr. Fauci, exposes Bill Clinton's, Bill Gates, blah, blah, blah. As of yesterday, this had been posted for 2 days. He had 750,000 viewers. And I'm not going to go through all 16 minutes of what he said, but I took quite a few clips out of what he said. And what you'll see on a lot of videos, you'll see it on certain news stations, you're going to hear a lot of near misses. People say things that, hey, yeah, there's kind of some truth in that. And then they throw out some conclusion that just doesn't match what any of the data shows. So let's just kind of go through some of this. I'll just call him Dr. Shiva because it's easier. Yeah, by the way, this guy is running for Congress. I'm not going to say which party he's running for in Massachusetts. This guy actually claims to have invented email. He also made a claim that hair dryers, if you use a hair dryer and blow it in your mouth, can actually kill COVID. Now, that was actually retracted, and you can no longer find it on YouTube. But this is an MIT PhD. Sounds very, very credible. So let's just kind of listen to some of this. This is interesting.
And with that, we'll bring in a man who has multiple degrees from MIT, including a PhD in biological engineering. He is also running for Senate in 2020. Welcome.
Biological engineering, MIT.
So nice to have you on the show today.
Great to be here, Christina. Hope you're well.
Great to be here. Great. He has a pretty good resume. PhD, MIT, Dr. Shiva. Keep in mind, he's not a medical doctor. He's a PhD. Not to say anything negative about PhDs. They're very important. But this is not a guy who's on the front line working in a hospital seeing patients. I just want to be very clear that he's a PhD physician. Okay, so let's go to, he is and by the way, she mentioned he is running for Senate, so we'll kind of keep that in context as well. Okay, so here he attacks Dr. Fauci, but then and that's okay. It's okay to attack people and kind of disagree with what they're saying, but listen to the very end of what he says. He makes a comment that's, I think, somewhat dangerous, where he actually comments against vaccinations and against distancing, saying that Fauci won't listen to anything if it doesn't have something to do with vaccinations and distancing. So let's listen to this.
Outbreak, the situation, he has received both praise and criticism. What do you think? How has the president handled the outbreak?
Well, he's handled, as the best he could, given the fact that he's surrounded by sharks and people who are not really advising him well on the science side of it. What I'm talking about is Fauci, infectious disease, without any real emphasis, which is a real issue, about the fact that it is a overactive, dysfunctional, weakened immune system that overreacts, and that's what causes damage to the body. And unfortunately, Fauci has not talked about that because the truth of that leads to a solution which has nothing to do with mandating vaccines and shutting down the country. And that's
Okay, so you heard that at the end where he's kind of talking against vaccinations and distancing, and he kind of, a lot of what he talks about is about, vitamin therapy. He goes into a lot of politics in this as well, and I just want to leave the politics alone. But let's go to the next one.
Both praise and criticism.
Whoops, sorry. So he attacks Fauci, and then he ends with that suggestion against mandating vaccines and sheltering in place. Anything that's against shutting down the country, Fauci doesn't want to hear. So I want to take a brief moment and talk about Dr. Fauci. Now, a lot of people have attacked him. Dr. Fauci is probably one of the brightest, most accoladed physicians in this country. He was director of the National Institute of Allergy and Infectious Disease for the last 36 years. He has advised 6 different presidents, both Democrats and Republicans. He has helped pioneer the field of immunoregulation in basic scientific observations that underpin the knowledge of the human immune response. He is widely recognized at delineating the precise pathways of immunosuppressive agents that modulate the human immune response. He's developed therapies for fatal diseases, including polyarteritis nodosa, Wegener's, and lymphomatoid granulomatosis. He has architected the president's emergency plan for AIDS relief, which is credited with saving millions of lives. He has contributed to basic HIV research and developed HIV medications. He has won the President's Medal of Freedom, which is the highest civilian honor given by the presidents, the National Medal of Science, 45 honorary degrees, numerous other awards, member of multiple medical societies, and he is editor of Harrison's Principles of Internal Medicine, probably the single most authoritative book in medicine in the United States. Now, if you're going to attack Dr. Fauci, maybe you can impugn the whole medical system, because that is what you would have to do to attack this man. This man is one of the highest highest integrity people there is. I mean, when our president stood up and said certain things, you could see him making faces and so on in the background. He does not care what people think about him. He is a very bright person that's going to speak his mind. Okay, enough about Dr. Fauci. I think you get my point. Okay, so more attacks, and he ends with an interesting comment on medical education. So let's listen to a little bit more of what he has to say.
Why they're advising him the way that they are.
Look, if you look, Christina, at the typical MD, many of them go into wanting to become a doctor out of some noble service. But fundamentally, the medical school education is really a big pharma medical education where the doctor's really trained, if this, then this. And the then is typically a pharmaceutical drug or some harsh medical intervention. How much governance and how much over-respect we give to MDs who unfortunately know nothing about the immune system. They don't study that in medical college or medical school.
Excellent points there, Dr. Shiva. Thank you.
Excellent points, Dr. Shiva. So let me just kind of unpack this a little bit. So he of course, he starts by, typical MD, wanting to become a doctor out of noble service. So I'm just going to kind of leave that alone, other than just to point out that it's a little bit insulting to myself and probably all physicians that are listening to this. Medical school education is really big pharma medical education. And, so he is placing medical education in with big pharma. Now, most medical schools typically are associated with large universities. We are taught by professors who are paid by the government, paid by the state. They are not paid by big pharma. They do research. They ask for grants from the government, and they may get a grant for the government to help support what they do. And they see patients maybe in the ER or patients in their clinic to help support their salary. There is very little, if any, big pharma involved in our medical education. Now, not to say that big pharma is not a problem in this country. Big pharma is a problem. We talked about Tamiflu. There are some people that talk about TPA. There's a lot, a lot of the early TPA research was done with big pharma involved. And I think a lot of doctors understand the limitations of a lot of studies that are funded by big pharma. But there are also clearly medicines that are very expensive. Humira would be an example of. It's been a life-changing drug for a lot of people with very severe rheumatologic diseases, but it costs $80,000. There is medicine for hepatitis C, a disease that kills people. $80,000, complete remission. So there is some upside to big pharma, but we understand where he's coming from. But again, I will classify that as a near miss. Big pharma is not all medical education and all medical studies, which is what he suggests. Then he talks about if then this, and the then is typically a pharmaceutical drug or harsh medical intervention. In other words, if somebody has a problem, what he's suggesting is physicians either automatically prescribe a drug or something harsh. Well, let's just say you have a heart attack and you come into the emergency department and we diagnose you with a heart attack. Well, there's a blockage somewhere in your heart. I guess if you would consider it harsh to put a needle in somebody's artery and go alleviate that clot, if you consider that a harsh intervention, okay. But that has been a life-changing event for a lot of people. It's the right thing to do. Pharmaceutical drug. Yes, there's some very expensive pharmaceutical drugs out there, but frankly, I won't speak for Dr. Malcom, but the drug that we recommend probably more than any in the ER is either aspirin, Motrin, or Tylenol, generic drugs that are very inexpensive. And if you are on a regimen of very expensive drugs, then what I would suggest is you can talk to your doctor and say, is there an alternative medication that I might take? And then the last thing he says is MDs who unfortunately know nothing about the immune system, they don't study that in medical college or medical school. Well, I found that kind of insulting because we have a whole course in the second year of medical school on pathology and immunology. And any physician remembers how painful this book was, The Pathologic Basis of Disease by Robbins and Cotran. That's a very thick book that we spend hours and hours and hours studying in the second year of medical school. So again, not getting his facts quite straight. He believes HIV is a hoax. Let's listen to this.
Look at someone like Fauci. He's a guy who architected the big lie that HIV is responsible for AIDS. And it's a much deeper discussion, but he built his entire career on that, not talking about the fact it's the suppression of the immune system. When people's immune system gets suppressed, you can react to all sorts of exogenous things coming in.
So again, a near miss, talking about, yes, it is the immune system being involved, but it's HIV, it's the virus that goes in and attacks and destroys the immune system. Again, why am I going down all these rabbit holes of all these different things that are unrelated to COVID? The reason I'm doing that, and you'll see it at the end of this video, is there's 750,000 people that support what this guy is saying, and they believe that COVID's a hoax, because what he is using is a lot of examples that people don't understand the answers to, and they sound real good. I mean, he's this person right here, he's got her hook, line, and sinker. She's sitting here nodding at everything he's saying, in addition to the people looking at his video. So let's go to the next one. Oh, listen closely to these numbers. So this is him using some facts to try to support his argument about, hey, COVID's not that bad. So just listen real quick. This is a quick clip, but I want you to listen to these numbers he says.
Said when Obama was running, you had nearly, I think, 60,000 deaths, right, with H1N1. Here you have close to maybe 10,000 deaths.
Okay, so when he said this 2 days ago, what he said was 60,000 H1N1 deaths in 2009, and he said here we have 6,000 to 10,000 deaths, and he said that 2 days ago. This was on April, it may have been April 10th or April 11th. So let's do a quick fact check on that. CDC in 2009 reports 12,000 deaths from H1N1 in 2009. And at the time of his, it was April 10th that he said it, he was saying 6,000 to 10,000 deaths. We had 20,000 deaths in the United States due to COVID. So he's not even getting his facts right here. Okay, this is another thing that we've heard a lot about, not just from him, but from other commentators. Diagnosis codes. That what these commentators are saying is that physicians are inflating the number of COVID deaths. And again, you got to get into the weeds with this one. And I'm going to explain this in a second, but just go ahead and listen to this interaction here.
Had coronavirus. Dr. Birx just came out and said they're classifying everybody with the virus as a death instead of dying from the virus as a death.
IT systems, they have to say, okay, Christina has this or this. That is called a diagnosis code. That code, Christina, comes from the WHO. So for coronavirus, as I understand, they created two codes. One code was you explicitly, had a test and you had COVID-19. The other one was completely nebulous. Well, it sort of smells like that. Maybe he's got some chest pains. Something so broad, but it was still under the COVID. The doctors in the United States received a letter from the CDC, as I have found out, that went to hospital administrators encouraging them to blur both of those codes. So if someone comes in, they have a pre-existing condition, someone with a chest pain, COVID-19, okay?
So yeah, someone comes in with chest pain and they die, just call it COVID. That couldn't be further from the truth. So let me explain to you exactly how a death certificate is filled out. This is a death certificate in the United States. This is a generic form. Different states have something, but they all look basically the same. And there's this section here called cause of death. And in the cause of death, what you say is, what's the immediate cause of death? So you might say pneumonia, but then there's these other things that cause it, or maybe causative to that. So I'm going to show you an example here of how that might look. So someone that dies of a cerebral hemorrhage, a bleed in their brain, that would be the direct cause of death. But it was caused because they had metastasis to the brain. There was cancer that went up to the brain to cause that bleeding. And that metastasis came from breast cancer. So would you say that it would be errant to say, oh, they're saying this patient died of breast cancer? No, they really died of a cerebral hemorrhage. Well, when you're looking at deaths from breast cancer, you would include this person in the count. So that is the idea. Here is a death certificate of somebody from the Spanish flu back from 1918. This is 1918, 10/7/1918. And it shows that the person died of bronchopneumonia. They died of pneumonia. And there's a lot written about, oh, why are we not seeing pneumonia deaths and we're seeing COVID deaths? And they're classifying them one way or another. Well, they're both going to be on the death certificate. And the way it's going to be written is COVID-19 is contributory to the cause of death. So it might be pneumonia, it might be ARDS, it may be some cardiac condition. But if someone has COVID, and that's COVID is what brings them in because they're having respiratory difficulty that the physician feels is related to COVID, COVID is going to go down here as a contributory diagnosis. And yes, it would be accurate to say that this person died of pneumonia, but when they're going back and seeing how many people died of influenza in this year, they do die of influenza. So physicians are not errantly just throwing COVID down here, just because we're having a COVID epidemic right now. They have to believe that this person had COVID and they died of this. So I'm sorry to take a long time to explain that, but this is something I've heard over and over and over, that doctors are inflating COVID deaths. And this is exactly the way a death certificate is done, and this is exactly how responsibility for COVID is going to get reflected in our population. Okay, he talks about social isolation.
Now, go look at the research, a landmark study. When you isolate people, that is one of worse than the detriments from obesity, smoking, and heart disease. Social isolation actually leads to upregulation of inflammatory compounds in the body and down-regulation of antiviral compounds. So you're basically increasing the person for viral infection by the amount of stress you're causing them from social isolation.
Okay, so let's look at the study he's talking about. He's talking about the study Social Relationship and Health by House, Landis, and Umberson, which is in Science in 1988. And it was a landmark study that showed that social isolation was a risk factor equal to obesity and hypertension, and I think smoking is a cause of morbidity and mortality. But what the study was specifically talking about is older people who are chronically isolated. And they were talking about true social isolation, where you're cut off from any social contact with others. So people had a low quantity or sometimes low quality of social relationships. And again, specifically speaking about older people who lacked spouses, lacked children, or any ability to communicate with them. We have Facebook, and we have FaceTime, and we have all these ways of communicating with people. We're able to walk outside and talk to our neighbor across the fence and so on. So again, a near miss. He's kind of taking this study that kind of suggested that, and he's taking it completely out of context to support the idea that social isolation or distancing is bad and that we should not be doing it. But he's using the wrong article to support what he's trying to say. Okay, so I have one more, and again, I appreciate everybody for kind of bearing with me. But again, this is a guy that got 750,000 views and lots of thumbs up and awesome. And I'm going to go to some of the comments that people leave about this exact video here in a second. So let's listen to what he says about viruses and scurvy.
Medical establishment, the pharmaceutical medical establishment for hundreds of years has built its entire foundation of always blaming a virus or a germ. Always. I remember scurvy when people's teeth would fall out and they had bleeding gums. Oh, it must be a virus. Well, it was deficiency in vitamin C 100 years later, when even people on the ground knew it.
Okay, so scurvy. What is scurvy? So scurvy in the medical establishment said, well, gosh, scurvy must be a virus. Got to be a virus. So again, what is scurvy? Scurvy was actually discovered by the Egyptians like 1500 BCE. It was documented by Hippocrates in 1497. All right, sorry. We're back live. We kind of lost it. Had a technical problem there. I don't know what happened. So anyway, and then in 1734, Dr. Backstrom, who's a physician, noted that scurvy is solely owing to a total abstinence from fresh vegetables and food and greens, which is alone the primary cause of the disease. So in 1734, we knew that scurvy was caused from lack of something in vegetables, and that was the sole cause. So when were viruses discovered? They were saying, before this ever happened, everyone was saying it must be a virus. When were viruses discovered? And if you remember from my previous talk, it was in the 1890s. So again, not right. So at any rate, let's listen to some of the comments that people made about this wonderful interview. Is Trump listening to this man? He should be. If Shiva is not elected to Senate, Trump should draft him as an advisor. 32 thumbs up. Such shame that so many people will not listen to common sense and reasoning. They have been brainwashed for too long. 282 thumbs up. Great interview. Dr. Shiva should be the one President Trump should be listening to. Dr. Shiva is spot on. Similar stuff by David Icke. So, interesting. So the point here, be very careful what you're listening to. A lot of these points I've heard made on other interviews, and they're just flat not accurate. Just not accurate. We need to be social distancing and or physical distancing. And let's go and talk here about the end game right now. So in game, kind of for some older people, for younger people, perhaps they might identify more with this as the end game. But we got to keep the illness curve flat. We cannot involve a significant rebound. We've made too much progress. We've seen the curve starting to flatten out. Things are getting better in certain places, even in New York and New Orleans. They're starting to see the light at the end, some light at the end of the tunnel. The number of deaths that were projected to be 80,000 down to 60,000. So how are we going to get there? One point. Hong Kong and Singapore. Remember Hong Kong and Singapore? They were doing so extremely well early on by hand washing and wearing masks. Well, they started to let people into the country and they're starting to see cases skyrocket. So we don't want this to happen where we're doing so well, and then we just throw it all away by not continuing all the measures that got us to such a great result. So the end game is to continue physical distancing for now, when we may see more masks in public. Remember what we said, this is a droplet or cough spread illness, and that by wearing masks, we can prevent people from spreading it from the person wearing the mask to somebody else. Remember, when I'm wearing the mask and I'm sitting next to Ed, me wearing the mask is protecting him. Him wearing the mask is protecting me. We're protecting other people by wearing the mask. We do need to continue testing of drugs that may work, including vaccines, because ultimately, when we are if we know that there are drugs that can severely blunt this disease, then that's going to help us all when we fall ill to this, whether it be a month from now or be 6 months from now. And again, vaccines a year or two from now are going to be the ultimate answer, which is going to give us all herd immunity. One things that are very, very important is we need to develop 2 types of rapid testing. Number 1 is testing of who has the disease. These are the nasal swabs. We need to know that when somebody is sick, do you have COVID or do you have something that may not be COVID? We also need a different test, a blood test that indicates who may have been exposed to the disease in the past. In other words, I hear a lot of people saying, I think I had COVID a month ago, so I must be immune, right? Well, there's some question marks as to whether having had the disease gives you full immunity, but we think that number is probably 90%, that if you've had it, the chances are very, very low that you'll catch it again, but it's not 0. It may be a 10% recurrence rate. So we need this test, because right now, if we went into Alpharetta or any community and we can test to know that 60% of the population has had the disease, then we were probably okay to be more aggressive in letting people out into the community faster. And then what we need is a slow release of healthy people into the population, followed by the less healthy. But after we have had the initial release of healthy people back into the population, we want to retest. We want to kind of revisit this idea and see where we're at. And only then and only then would we release the less healthy, the older people back into the population in a safe manner. And there's clearly there's going to be a lot of permutations to this. I don't know, maybe we get drugs that are excellent and work great, and we may be able to accelerate this process. Vaccines may be a couple of years behind, and we may have to be careful of this process every year when we go through it. But these are the basic concepts that we have to embrace. We have to continue social distancing. We can't just throw our hands up and say, well, everything's getting better, so let's just get back to normal. That is a very errant thing to do. Singapore, Hong Kong, great examples. We need to develop the rapid testing, and it's going to be a slow release. It's not going to just be everybody get back at it. Thank everyone for their attention. Thank you for listening to my little rant here this evening. But just listening to all this garbage and nonsense that we're hearing on the TV. I just want to kind of give y'all some of the tools and kind of some of the
Facts.
kind of some of the facts that are behind some of that stuff. So, I think Ed wrote down some questions here. Flip the camera around, and I know we're almost at an hour here, so I kind of went on a little long tonight. Apologize for that, but hopefully we get some good questions here. Let's turn the camera around. Let's kind of bring this up. A little dark in here. Let me go turn the light on.
Somebody asked about long-term damage of the disease, like to your lungs. We don't have as much information on this as we'd like, but there's been some concern that anytime you get really sick, you can hurt organs. You can hurt your kidneys. You can, hurt your brain. You can hurt everything. Specifically about this, I don't know. I know there's been talk about this, and that's the next frontier. Do you know anything about long-term effects of the disease?
Well, I don't. Frankly, when people kind of get over it, I'm sure they'll have a follow-up with a pulmonologist, and there's pulmonary function testing and so on that can be done. As we know that there's not, major damage to the airways, and as long as people don't have, significant maybe barotrauma from being on the ventilator for a while, I mean, my personal take would be that people are probably going to, be fine. They're not going to feel good for a little while. I mean, if they've had fluid in their lungs for a while, it's going to be a couple months of recovery, but I don't think there shouldn't really be any long-term damage from that, but our pulmonary colleagues might have a slightly different answer. But
and then moving on, just because of time, somebody was saying, are they using scare tactics? And I guess some of this, I don't know. That's a tough one. I don't think they're really using scare tactics. I think they're just trying to put the facts out and remind you to stay safe.
Who are you talking about the scare tactics?
That was a question that came up during the thing. I didn't totally maybe have the exact his exact question there, but I don't.
Well, I don't think anyone's using scare tactics to get us to call COVID deaths. I mean, that kind of came up in there. But nobody's saying you need to call all these COVID deaths and write that on a death certificate. No, the physicians, we do not get that kind of pressure to do that. Yeah. That's just an ignorant comment.
And I think something everybody wants to hear, and we ought to jump to as we get to the end is, as we've seen it a couple times, trends in Atlanta, trends in North Fulton. What are we seeing? I think we're seeing stable. I think where people are definitely getting it. People are being admitted to the hospital. I think our hospitals are handling it well. I think we're, thank goodness we haven't been overrun. We have room in our hospitals.
I think the main thing is people feel like they're just going to get, the ERs are kind of being overrun or anything, and that's not the case. The emergency departments, we're there to help people. That we're not being overrun. Clearly, we have a lot of bandwidth to take care of people. Mm-hmm. And kind of one of the concerns is that people with, say, gallbladder attacks and appendicitis and and heart disease are staying away from the hospital because they're concerned about the COVID in the community. And just I would just want to reiterate that is just not the case. I mean, hospitals are very, very careful to make sure that COVID is, the patients are, segregated, and that the cross-contamination concern is just not going to happen. The waiting rooms are essentially empty. They're not full of people coughing.
They are empty.
Or anything like that.
Yeah, and anybody that comes back into the hospital anyone coming into some of these North Fulton hospitals are their temperatures checked and before they come in.
There's a lot of screening done, and anyone that may have any concern, a mask is immediately put on the patient to make sure that they're not spreading, droplets and so on in the ER and to other patients. So you definitely want to reiterate that.
And then people have asked about upcoming testing. I tell you, there's been 2 steps forward, 1 steps back. Some of the tests that have been kind of pushed out early maybe have found to be not as effective or not as sensitive, and so some of those have had to go offline. So I would say we're kind of marching forward where we we're testing more, but it's not just the exponential growth of that. It's been kind of slow and painful, but yes, we are.
There's definitely focus on that. There's definitely focus on looking at, widespread testing, and we keep hearing that. It's just, unfortunately, just been a little bit slower on the uptake than what we'd like. Areas, other parts of the country, again, very similar, I think, to Atlanta. There are a couple communities, I think, Albany, Georgia being one of them, some very specific communities that have been kind of hit hard. Again, we talked about New York and New Orleans, but I was on the call today with physicians across the country, and they're seeing other hospitals similar, that some hospitals are kind of filling up, but nobody's really at their breaking point other than the hospitals in New York and the surrounding area. So we're doing good, and the physical distancing that we're all doing, there's no question that is making a huge difference. So this may go on for another couple months. I know we're only about 1 month into this, and my wife and others are kind of going stir crazy, but I think me too. But I think we're realizing the benefit, and this is one of these times we're going to look back and be very thankful for what we did. And the suggestion that some people have that, hey, the death rate is just not as high as it was supposed to be. Why are we doing all this? That is looking in the that's looking in the rearview mirror. That is the wrong way to be looking at it. What we need to say is we've done a great job, and we have, in our country is better off for it, and a lot fewer deaths, and just doing a lot better job than we anticipated. And just kudos to all the governors and all the leaders who have been behind this effort. That's all I can say.
Yeah, stood up when it's hard to make those decisions.
Yeah. Captain Crozier. Yep.
Captain Crozier stood up.
Yeah. All right.
Good. I think we really did hit most of the questions. And just.
All right. Well, we appreciate everybody hanging in there with us tonight. Hopefully you learned something. I'll try and do a better job of getting to everybody's questions. It does take a fair amount of effort. I'm not sure that I'll be with everyone next Monday, but I will kind of keep my ear to the ground and see what's going on, and certainly let everybody know if we go on live again in the near future. So I appreciate everybody listening, and again, happy to answer your questions on Facebook. Thanks, everyone.
Bye.